So yes, Dr. Stoll and I were able to work together and come up with a presentation, and we're just gonna mostly go through some cases of the most common types of headaches that we see in the neurology office. And so for any of these types of cases, I'm sure many of the people here will be familiar with these types of headaches. And I would say with any of these types of headaches, referral to a neurologist is warranted or can be had. And so let's go ahead and get started. Sorry. There we go. Okay, so just kind of an overview about headache. As many of us probably already know, it is one of the most common disorders seen both in general pediatrics and in neurology in childhood and adolescence. And so there's a lot of estimated prevalences of headache, but some of the most common numbers I found would be at least 30 to 40%, which is, a pretty huge number for the pediatric population. And as studies have more and more epidemiologic studies have been done, they've shown that prevalence is actually increasing year after year. So it is something that I feel like is becoming more common to be seen amongst the children and adolescents in the US. Of course, prevalence and occurrence does increase as kids get older. And I think adolescence is probably the age where we see most of headache. And then kind of in general, when we think about headaches, we like to classify them as primary or secondary. So I was just going to go over that definition real quick. So primary headaches are headaches that result from headache disorder itself. And so this is the most common cause of recurrent headaches in the pediatric population, which of course migraine, as many of us know, is the most prevalent. But other common types are tension type headache, as well as medication overuse headache. And when we talk about secondary headaches, we're talking about headaches that result from an underlying condition. So this can be, a wide variety of causes. And I listed some here, such as infection, trauma, neoplasm. But a lot of these types of headaches are associated with what we call red flag symptoms. So a lot of the time when we think about headaches, the first step is to kind of ask if it is primary or secondary. And if there's concern for secondary, then we kind of look for these red flag symptoms. So here's a good table, and in neurology, we like to use this mnemonic called the SNOOP mnemonic. And this table is showing what's called the SNOOP 4, but in recent years, more P's have been added to the end of it. But these are kind of the main red flag symptoms that we look for when trying to assess for primary versus secondary headache. So as you can see, S is for systemic symptoms. So a lot of times that'd be other symptoms like fever, weight loss, night chills, things that go along with the headache that are suspicious for a secondary cause. N is for any sort of neurologic symptom. Most of the time, we're looking for focal neurologic signs, so motor weakness, sensory loss, vision loss, those kind of things. O is onset, so thinking about sudden onset headaches that reach their peak intensity in less than 1 minute, what we refer to as thunderclap headaches. That's concerning for a secondary cause. The second O is onset of age. So in our situation, it'd be less than 5 years of age. Something to just think about in terms of other causes of headache if a child under 5 is presenting with new onset headache. P is pattern change. So that'd be, stable headaches that have now changed and become worse, or, headaches that are worsened by specific maneuvers like bending over, coughing, as well as certain postures that aggravate headaches. And then the rest of the P's, as you can see, are papilledema on fundoscopic exam, and not so much related to us as pregnancy, but maybe in adolescent age, if new onset headache during pregnancy or change of headache in pregnancy. And then the final thing is if there's a specific type of phenotype to the headache that kind of keys us into a more rare condition that may represent a secondary cause of headache. So moving on to the first case, first I want to talk about this 10-year-old boy who has no significant past medical history and is presenting to your office for headaches. These headaches started 2-3 years ago, and just over time, the reason they're seeking care is they've kind of increased in frequency, severity, and duration. They're now occurring once a week, 7 out of 10 pain, and each lasts around 3 to 4 hours. So when you ask about the headache, he says that it hurts kind of in the front, bifrontally. The quality is this sharp throbbing pain, and it is associated with some symptoms such as nausea, vomiting, and sensitivity to light and sound. It does feel better by lying down, sleeping, and it is worsened by physical activity. No visual symptoms with headaches, no worsening with bending over or coughing, no nighttime arousals, and it does sometimes improve when mom gives him some ibuprofen at home. Otherwise, as you can see here, the rest of his history is pretty normal. There is a family history of migraine in mom and grandma, and otherwise he's a great student, has no other medical problems. His general physical exam is very normal, nothing kind of alerting to any sort of issue there. And then neurologic exam is also normal, no focal neurologic deficits. He's very pleasant, very appropriate for his age. So talking a little bit about headache history, I just kind of put some of the main questions to think about whenever a patient comes to your clinic for headache. So a lot of these, I think, are things that we think of on anyways to think about, but it's nice to have a list, and at least for me in my head whenever I see a patient headache. So, you know, obviously, when did your headache start? How often? Where is the location of headache? What does the headache feel like, or what's the quality of the headache? How long do your headaches last? Are there other associated symptoms? What makes your headaches feel better or worse? And then what medicines have you tried for headache? So kind of like these standard questions to ask every patient who comes in to your office with headache. This is a slide that just talking about the physical exam in terms of headache and things to look for that may or may not clue you into maybe another secondary cause of headache. I won't go through all of it, but I think kind of the key points are, you know, any vital sign changes that may key you into another cause for headache, fever obviously being the most obvious one. And then like Dr. Cullen or Dr. Marshall talked about, you know, macrocephaly is something to keep your eye on. So if a patient comes in with headache and is macrocephalic, just kind of makes you think a little bit more about maybe a secondary cause of headache. And then other, you know, papilledema, something I already mentioned on fundoscopic exam, any sort of altered mental status, and any focal neurologic deficits. So asymmetric motor exam or asymmetric sensory exam is always something to look out for. And then any sort of rashes, bruises, kind of other marks on the skin exam that may key you into a more systemic issue causing headache. So this is just kind of a brief or a comprehensive, I should say, table that goes through the physical exam when in terms of looking for signs for other causes of headache. And so the case I spoke of earlier, this 10-year-old boy coming with headache, is pretty classic for what we would call episodic migraine. So in terms of headache, we always refer to this international classification of headache disorders, currently in its 3rd edition, or ICHD-3. So a lot of the headaches I'll be talking about, I'll refer to the definition as listed by the ICHD-3. So for episodic migraine is classified as recurrent headache disorder that manifests in attacks lasting 2 to 72 hours. And then typically the headaches are unilateral, pulsating quality of moderate to severe intensity, aggravated by routine physical activity, and associated with nausea and or photo and phonophobia. So this, you know, it's a lot of words, but it's kind of the, you know, copy paste in terms of the diagnostic criteria. And I think kind of a lot of part of this is with that paragraph earlier summarized, but I think the key points are, you know, migraine should last for at least 2 hours in pediatrics. And that's usually talking about duration untreated or unsuccessfully treated. And then it has to have at least 2 of the following, being unilateral location, pulsating quality, moderate to severe pain, and aggravated by physical activity. And then also has to have at least 1 of the following, which is nausea and or vomiting and photo and phonophobia. And of course, not better accounted for by another diagnosis. So some differences with migraine in children and adolescents is that migraine is more often bilateral. So the unilateral quality may or may not be true for children and adolescents. It is usually frontotemporal. And actually in adults, the attack duration is 4 hours, whereas in kids it's 2 hours. So attack duration can be shorter in kids. We talked about the most commonly associated features listed there, photo and phonophobia being the most common ones. And then of course, in younger children who aren't able to quite articulate exactly what they're feeling, you have to kind of infer based on the behaviors, the photo and phonophobia parts of their symptoms. So episodic migraine are headaches that occur less than 15 days out of a month. And then treatment is varied, but usually starts with lifestyle measures followed by abortive medications and then preventative medications. I've listed the most common lifestyle measures that have been shown to be effective in treating migraine. So of course, drinking enough fluids, regular sleep, eating regular meals, not drinking too much caffeine, increased physical activity, and managing stress are all kind of factors that play into preventing migraine. In terms of medications, you can use over-the-counter analgesics for abortives, such as ibuprofen. There's triptans that are used specifically for migraine. So rizatriptan is the most common one we use in the pediatric population. And then, of course, you can always use antiemetics for the nausea portion. So something like metoclopramide or promethazine. In terms of when to start a daily preventative medication, we often consider that for attacks that are frequent or severe. And what we classify as frequent is 4 or more, or roughly more than 1 or more headaches per week. So 4 or more per month. And for preventatives in children, we usually like to start with nutraceuticals, which include magnesium oxide, riboflavin, CoQ10. There's kind of over-the-counter vitamins that parents can easily pick up and take daily. But other options are cyproheptadine, beta blockers such as propranolol, tricyclic antidepressants, mostly amitriptyline, and then anti-seizure medications like topiramate. So the next case I want to talk about is the 16-year-old girl. She has a history of anxiety, and she also is presenting to your clinic for headaches. Her headaches started when she was 11 to 12 years of age. And initially, they were mild and intermittent, though they've worsened in the last year. They occur every other day. They're 9 out of 10 in intensity, and they last several hours to all day. Her pain is right-sided frontotemporal with a pounding, throbbing quality. And she also has nausea, vomiting, sensitivity to light and sound, neck pain, and fatigue. Her headaches are improved by lying down and sleeping, and is aggravated by physical activity. She also does not have any vision symptoms, worsening with bending over, coughing, or nighttime arousals. Does not use any medications at this point because she's tried ibuprofen and Tylenol, which do not help. Her past medical history is just significant for anxiety, and she's on an SSRI for that. Otherwise, her history is pretty benign. She does have a pretty extensive family history of migraine. She otherwise is a very high achieving girl in the 10th grade, ready to take her ACT and go to college soon. Her physical exam is also unremarkable, as well as her neurologic exam is all very normal, no focal neurologic deficits. Again, a very bright and articulate girl who can kind of tell you exactly what's going on. So in this case, this 16-year-old girl would qualify for chronic migraine. So again, here's the exact diagnostic criteria, kind of copy pasted from the ICHD-3. But the main takeaways from this is that they are headaches that fulfill migraine or migraine with aura that occur greater than or equal to 15 days out of a month and have been occurring for more than 3 months. So any type of headache that fulfills the criteria that we talked about earlier, so it sounds like migraine, but then are occurring kind of in this time frame and in this frequency would qualify as chronic migraine. So for chronic migraine, it can be difficult to treat. These patients are often, have often gone through multiple types of medications or treatments and failed, and can have significant disability because of their head pain and their headaches. So the things to mostly focus on in this case are lifestyle modifications and preventative therapy. Abortive therapy does have its role in chronic migraine, but there's always a concern for medication overuse headache. It would not be uncommon for someone like this case, like the 16-year-old to come in and she's taking ibuprofen or Tylenol every day. And that can make things a little more difficult. So a lot of times for chronic migraine, the focus is on lifestyle modifications and preventative treatments. So for preventative therapy for chronic migraine, the medications like we talked about earlier, usually try to start with nutraceuticals, but you can move on to more prescription medications. That's always a good option. But there's a lot of non-medication options, which are often more, just as if not more effective for chronic migraine. So behavioral therapy, so CBT, biofeedback, relaxation training, there's great evidence that these are good to help reduce number of headache days in patients with chronic migraine. There's neurostimulation devices. That's some brands are called neuroencephaly. If the kid is old enough, it's not approved for under 18, but sometimes in older adolescents, botulinum toxin injections can be approved. And then, of course, hopefully in the future, we'll have more availability for monoclonal antibodies to CGRP, which are new emerging therapies in adults that have proven very effective for treating migraine. So the next case is a 17-year-old girl. She has a history of ADHD and she presents with headache as well. Her headache started 2 months ago, and initially they were intermittent, but they've worsened in the past 1 month. Headaches are now daily and constant, so she is never without a headache at this point. Her pain is a little more varied. It can be right or left, frontal, temporal, or parietal. Her quality is also described as pounding and throbbing. Associated symptoms for her are nausea, vomiting, sensitivity, light and sounds, and neck and back pain. Her headaches are actually alleviated by sitting up and by resting, and are aggravated by physical activity, bending over, coughing. Some other associated symptoms that she tells you about is that she has some vision blurring or blacking out, usually just lasting a few seconds, but can be precipitated by her bending over or coughing. And then headaches do seem to wake her up at least once a week. And she clarifies that she's woken up because of the headache pain. It's not that she wakes up and has a headache. She takes ibuprofen daily, which only helps some of the time. She just has a history of ADHD and is on methylphenidate. Really no other past medical history, does have a family history of migraine. And she's in the 12th grade, makes B's and C's, but overall does okay in school. Her physical exam is pretty benign as well. She is noted to be obese. Her BMI is 34, but otherwise the exam itself is normal. And on her neurologic exam, it's overall non-focal, and she's otherwise well appearing. But on fundoscopic, well, first on looking at her eyes, you notice that she's unable to fully abduct her left eye when looking at her extraocular movements. And then when you do a fundoscopic exam, you do see that she has grade 2 papilledema bilaterally. So for this patient, her presentation is pretty classic for idiopathic intracranial hypertension, also known as pseudotumor cerebri. So when diagnosing pseudotumor, there's these revised diagnostic criteria that were put out, I think in 2012 by Friedman et al. And briefly, it's papilledema on fundoscopic exam, and otherwise a normal non-focal neurologic exam, except for maybe some cranial nerve abnormalities, most commonly a lateral rectus palsy, and so an inability to abduct fully. Her neuroimaging should be normal, and that's with and without contrast, as well as having a normal MRV. When you do a lumbar puncture, if you get spinal fluid, the CSF composition should be normal, should not show signs of infection or inflammation. And then for children, the lumbar puncture opening pressure should be greater than 280 millimeters or 28 centimeters of CSF. Here is again, the ICHD-3 diagnostic criteria. So a new headache or worsening of pre-existing headache, fulfilling the following criteria we kind of discussed already. Someone who's already had IIH diagnosed, or a CSF opening pressure greater than 280 in children. And then the headache has developed or significantly worsened in temporal relation to the discovery or the diagnosis of IIH. Some commonly associated symptoms are headaches can be associated with pulsatile tinnitus as well as papilledema on fundoscopic exam. So in terms of what it exactly looks like if a kid comes to your clinic with IIH, headaches are not unlike migraine, the headaches can be kind of more varied. They can occur at any location. They usually are described as daily, worsening with Valsalva and certain postural positions, mostly laying down, bending over, and then sometimes are described as more severe in the morning. Otherwise, they can look like migraine in that they have associated nausea and vomiting and photophobia, as well as neck and back pain. Some key symptoms to look out for to kind of clue you into the diagnosis are, transient visual obscurations, which are the brief and usually precipitated by Valsalva, and patients describe a blackening or darkening of vision that then goes away, lasts just a few seconds. Diplopia due to cranial nerve 6 palsy, patients being unable to fully abduct their eyes, and then pulsatile tinnitus, kind of this whooshing sound in their ears. And the main concern with IIH is the persistent irreversible vision loss due to optic nerve damage. And so this is a diagnosis that we take very seriously and that we work up urgently, usually with admission for MR imaging as well as a lumbar puncture. Here's a slide of the kind of the fundus and the different grades of papilledema. So as you can see on the very left, the normal, you should be able to follow the blood vessels to the optic disc and see these kind of clear, nice sharp disc margins and a nice yellow color. And as you go over close to more to the right, you see that the disc margins become more and more obscured, can develop this halo around it. And eventually, if you get all the way to grade 4 and 5, you can barely even tell where the disc is. And there's kind of this complete loss of any sort of normal anatomy there. And that's kind of what we're looking for whenever we look in the fundoscopic exam to see for papilledema. For treatment of IIH, the main treatments are lifestyle changes and medications similar to migraine, but a little bit different in that for IIH, weight loss has been proven to be one of the most effective therapies for treatment of the symptoms as well as papilledema. And then often weight loss is paired with the medications. Usually acetazolamide is the first, or Diamox is what we use first, but other medicines, if acetazolamide is not tolerated or fails, include topiramate or furosemide. In terms of procedures, optic nerve sheath fenestration is something that can be done to preserve vision, but typically does not resolve the increased pressure in the head. And then neurosurgery will sometimes, in severe cases, put in a shunt, a VP or LP shunt, or can do neurovascular surgery, can also do venous sinus stenting if there are signs of venous sinus stenosis on MRV, which may or may not be contributing to the increased pressure. The last case is a 15-year-old boy. He also has no significant past medical history. He's also presenting with headache. His headache started 2 weeks ago after he had a helmet-to-helmet collision with another player during a football game. He did not lose consciousness, but was disoriented and off balance initially. He was taken out of the game, and then about 1 hour after the injury, he developed a headache with nausea, vomiting, and so was taken to the local ER. There, he had gradual resolution of his headache and returned to baseline mental status. The CT head was obtained and normal, and then the following day, he had return of headache, which has since persisted for the past 2 weeks. His headaches are daily, last around 4 to 5 hours each. He has complete retrograde amnesia, the event, and the following 2 days after the event. And currently, alongside headache, he's having issues with short-term memory and brain fog. His pain symptoms are, his headaches are described as bifrontal or bitemporal, a sharp stabbing, throbbing quality. He has nausea, vomiting, sensitivity, light and sound, neck and shoulder pain, as well as lightheadedness with his headaches. Head headaches are resolved by lying down and resting and worsened by physical activity. He does not have any visual symptoms, no worsening with Valsalva or bending over, and no nighttime arousals. Ibuprofen does help with pain. He does take it daily. He otherwise is very healthy. Past medical history is very benign, no family history of headaches or migraine, and currently does well in the 9th grade, making A, Bs, and Cs. His physical exam is also, again, very normal, as well as his neurologic exam is also very normal. So the patient in this case describes perfectly what's called either post-traumatic headache or a concussion. So post-traumatic headache, according to ICHD-3, is defined as a secondary headache that does occur after injury or with trauma to the head or neck. It usually presents within 7 days post-injury and 7 days after gaining consciousness or 7 days after recovering from the ability to sense or report pain. The key there is that the headache occurs in close temporal relation to the head injury. Can be associated with other symptoms, including dizziness, fatigue, cognitive issues such as reduced ability to concentrate, psychomotor slowing, memory issues, insomnia, and then psychiatric symptoms such as anxiety, personality changes, and irritability. So different definitions in terms of the length of the headache. So acute post-traumatic headache is headache that resolves within 3 months of its onset. Persistent post-traumatic headache would then be headaches that persist greater than 3 months after. And some kind of pearls are that the severity of the injury does not necessarily predict the severity of the symptoms. There have been patients who had a kind of minor head injury, maybe from a football game, who then go on to have persistent post-traumatic headache that's very refractory to treatment. But then there are some patients who get a really bad MVA and have very mild symptoms. So can't really take the severity of injury to predict anything about how symptoms would respond to treatment. Female sex and adolescence have been shown associated with increased risk of headaches after mild TBI as well. And those classified as a secondary headache, the clinical phenotype is similar to primary headache disorders. Majority of headaches do resemble migraine and are followed, also followed by tension type headache. You can have like this mixed phenotypic presentation. And then some things that increase the likelihood of developing post-traumatic headache are pre-existing or family history of migraines, and associated symptoms are sleep dysfunction, mood issues, sensory disturbances, and issues with cognition. Majority of these patients do well. They recover in 2 to 4 weeks after injury. And treatment is really based on the type of headache that the type of primary headache that it similarly resembles. So if it resembles a migraine, medicines and treatments for migraine are effective, including analgesics, triptans, as well as typical lifestyle modifications. And then a key point with post-traumatic headache is that there's a high risk for medication overuse because these patients typically will have really bad headache after injury and take lots of over-the-counter meds daily. So that's something to counsel patients on. Same with treatment of persistent post-traumatic headache. You kind of tailor the treatment based on the primary or headache type that it resembles. So again, we would treat for more than 4 headaches per month or severe headaches, and you can use all the same types of preventative medications used to treat chronic migraine in this case. Other options for non-medication treatments are occipital nerve blocks and cognitive behavioral therapy. In terms of the return to play or return to learn, that's something that's really important for us in the pediatric population. So CDC does have these guidelines to help us. So the key points for some of the guidelines are that strict rest is encouraged 24 to 48 hours after injury. And there is increasing evidence that kind of gradual aerobic exercise can promote recovery. There's this window of vulnerability with increased risk of concussion 7 to 10 days after injury. And, there's not a set timeline that these kids should follow. The CDC and studies have shown that really it's just based on symptoms. So if a patient is having symptoms with increasing activity, whether it's practice or schooling, then, the next step is to pull back on those activities until symptoms resolve. And so here's kind of exactly from the CDC website, their 6-step return to play progression. Kind of exactly what we talked about, but basically it's a gradual return to activity until based on a patient's symptoms until they are symptom free and until they're back to full activity. One of the last things about post-traumatic headache is that there's something called the Lystedt law that was passed, I think in Utah, where a patient suffered a headache, a concussion, and then returned to play, and then ended up dying. And so there's laws now here, and this specifically in Kentucky, and I just highlighted the key points where if an athlete does sustain a concussion, by law they're required to have an evaluation by a physician or a licensed medical healthcare professional before they're allowed to return to play. And if they're deemed to have a concussion by a physician or licensed healthcare provider, then they need written clearance to return to play afterwards. So in conclusion, pediatric headache is a common disorder in childhood and adolescence. Majority of headaches are primary headaches, specifically migraine. If with any headache, you should always be screening for secondary headache disorders. So the Snoop 4 mnemonic is something we use commonly to assess for those. Headache disorders are clinical diagnoses, though, that can be determined just based on history and exam. And so the 4 common types of headaches I went over: episodic migraine, chronic migraine, idiopathic intracranial hypertension or pseudotumor cerebri, and then post-traumatic headache or concussion. These are all disorders that I think are commonly seen in the pediatric population and can warrant a referral to neurology. So here are my references, and happy to take Dr. Soul and I are happy to take any questions.
All right, thanks so much, Dr. Gong. That was an excellent talk. We have a question. So how many concussion can a patient have before recommending no return to contact sports, assuming they have recovered from the previous concussions?
So I can maybe take this one to
Yes,
contribute. So I think that there isn't an overlying recommendation. So there's no practice parameter. The CDC publishes the 6 steps return to play. That's actually taken from an international consensus conference on concussion, which met, I think, the 5th or 6th time this year, I believe. But from that conference, there is no recommendation for retirement from sports. So that's a very good question. So it does, leave it to some extent to the judgment of the physician. And there have been patients that I have retired from sport. I think that, the traditional previous notion of concussion being a condition where you have transient dysfunction and then return to baseline, we now know is more concerning for chronic traumatic encephalopathy, particularly among those who are exposed at risk to repeated concussion. But I think that, it's unfortunate, but there's not a specific recommendation by any of the academies, CDC, or the International Consensus Conference on retirement from sport. So it does kind of then revert to, well, what's best clinical judgment? Well, suffice it to say that you need your brain. So there are times when I have redirected somebody to a different sport that maybe has less risk of concussion.
All right. Thanks so much, Dr. Sewell. So there are a few other comments. First for Dr. Gong. Happy birthday, Dr. Gong. Thanks so much
Thank you.
for the talk on your birthday. So the other question is, can you walk us through which daily preventative medication you most commonly prescribe someone with migraines after failure of nutraceuticals and vitamins?
Okay, sorry, can you repeat the last part of the question, Dr. Carcass?
So can you walk us through which daily preventive medicine you most commonly prescribe someone with migraines after failure of nutraceuticals or vitamins, like after magnesium and B2 and things like this?
I think after nutraceuticals, the main reason we like them is because they have little to no side effects. So after nutraceuticals, I don't know if there's a most common, because I think it's just based on which side effect profile fits the patient the best. So, I think if I can get a double benefit from the prescription medication, maybe a kid who has issues with sleep and I can give him amitriptyline at night to help with that, or something like in those kind of lines. That's kind of what I would say. But I think probably younger kids is, I think cyproheptadine is the most common one, just because it is pretty well tolerated. And then as they get older, I think for me, it's a toss up between amitriptyline, topiramate, and propranolol, just based on the patient themselves and what other factors are going on with life. If they're like a high achieving high school student, then I'd steer away from topiramate because it often is associated with kind of this brain fog or word finding difficulty. Maybe if they have a little bit of anxiety, then you can choose, amitriptyline or propranolol to help with that. And again, like sleep issues, you can always try amitriptyline at night. What would you say, Dr. Soul?
I would agree with that. So there are comorbidities. So for example, if a child has epilepsy, the anticonvulsants that have shown to be safe and effective for prevention of migraine are topiramate, zonisamide, Keppra. And so we might, choose one of those medicines. We try to, within neurology, we try to respect each other's area of interest and maybe kill two birds with one stone, so to speak. Your point's a great one about amitriptyline. So we're always looking out for behavioral health. So we're asking these questions about sleep, hydration, et cetera. And if sleep is an issue, then amitriptyline is a good one at a low dose. And then like the essential tremor is actually a comorbidity with migraine. So that might put us in the frame of mind of treating with propranolol, for example, for prevention if the nutraceuticals fail. So yeah, we kind of tailor it according to the coexisting or comorbid conditions.
Perfect. Thanks so much. There's another question. Can you comment on who is allowed to evaluate patient for return to play after concussion, like MD versus MP, and how do we accelerate getting patient into clinic?
So I was going to ask Paul, is this actually copied and pasted from the that House bill, the Kentucky concussion law? Because it's a little bit different than my understanding. So if you read, everything's in the language, right? So if you actually read it, it says, or a licensed healthcare provider. I was under the impression for a long time that it required a physician to return to clear the child to return to play. But this, if this is copied and pasted from the Kentucky concussion law, then I think, this is the kind of the final word. So maybe we should think about this differently. So it's a licensed healthcare provider in this case. So a nurse practitioner or a PA would be okay.
Perfect.
Yes, that was my understanding as well, Dr. Saul, when I looked up the law. Yeah, this is copy and pasted. It's a little paraphrase, like in terms of I took out some sentences in between, but the actual wording is copy and pasted. So my understanding was, a physician or any NPPA, anyone who's licensed.
So I have a question. A few years ago, I think was it 2017 or something, there was a clinical trial published in New England Journal of Medicine comparing placebo, amitriptyline, and topiramate, and they said there was really no difference between any of it. Is it really placebo, or do you guys really believe in topiramate and amitriptyline?
Well,
I think, go ahead.
So that's a good question, Dr. Caracas. So that was called the CHAMP trial. That was completed in, I believe, it was completed in 2012, and I believe published in 2013 in the New England Journal. We were among the top third of enrolling sites for the CHAMP trial. So it was 3 arms, amitriptyline, topiramate, and placebo. And it was a little bit curious that the placebo group actually beat out the amitriptyline and the topiramate group in terms of the reduction in frequency, severity, duration of migraine. The good news was that all 3 groups experienced reduction over time in their migraines. So there is conflicting, data. So there was a separate study that was completed actually prior to the publication of the CHAMP trial of just topiramate versus placebo, and found it to be significantly more effective than placebo. So topiramate, strangely, was actually approved in the adolescent age group for prevention of migraine while the data were being analyzed for the CHAMP trial, which is odd. The FDA sometimes loses their mind, but in any case, I think they all 3 are safe and effective, but we certainly monitor closely for side effects.
Okay. So there are some other questions. But an injured athlete cannot return to play unless physician signs off. That was a question following the previous question.
Yeah, so my understanding based on the law, and all these laws are actually modeled off the original Lysted law. But if a athlete is deemed to have a concussion by a physician or licensed healthcare provider, it seems like they need to see a physician. Based on the wording of the law, it seems like they need to have written clearance from a physician. I think maybe that's what you were thinking, Arsol. But before they are allowed to return to play, they need to be cleared by a physician. And I think what they're referring to in the first paragraph is an evaluation that's typically done maybe at the at the site, like on the field, or at the game or something like that, more immediate. And then if whoever is there, whether they're a NP or a physician, deems them to meet criteria for concussion, then later on, they kind of down the line, they have to be seen by a physician and have that clearance to return afterwards. That's my understanding of the law. I'm not a lawyer, but based on what I've read into, that's my understanding of what the law says.
Yeah, I would agree. Now that I look at it a little bit closely, it does say written clearance from a physician.
Mm-hmm. Yes. So I think
I guess we have to respect that for and abide by that for the law. So
yes.
Thank you so much.